Hello everyone, my name is Rose Lopchant. In this Grand Round project, I'm gonna presenting about pulmonary hypertension. Pulmonary hypertension refers to high blood pressure in the pulmonary arteries, leading to complication in the heart and lungs. Unlike systemic hypertension, pH specifically involves the blood vessels supplying the lungs. Its pathophysiology includes the narrowing, obstructing, or destroying of these arteries, leading to increased pulmonary vascular resistance. This resistance forces the right ventricle of the heart to work harder to pump blood into the lungs, often resulting in hypertrophy, dilation, and ultimately failure, a condition term called core pulmonary. pH is classified into five groups based on its cause, with group 3 directly related to lung disease like COPD, through chronic inflammation, hypoxemia meaning low oxygen level, and structural lungs change, induced vascular change in contributing to pulmonary hypertension. The morbidity and mortality associated with PH and in COPD are substantial due to the added cardiovascular burden, making effective diagnosis and management critical. The etiology of pulmonary hypertension in COPD is multifactorial, with chronic hypoxemia playing a primary role. Hammond and Berger 2020 show that hypoxemia or persistently low oxygen level triggers a compensatory vasoconstriction mechanism aimed at optimizing oxygen exchange by reducing blood flow to better ventilate lungs region. Over time, this response becomes maladaptive, resulting in chronic vasoconstriction and vascular remodeling. This remodeling involves smooth muscle hypertrophy, thickening of the intimal layer, and increased extracellular matrix deposition, all of them contributing to increased pulmonary vascular resistance. Chronic inflammation inherent to COPD exacerbates endothelial dysfunction, reducing the production of vasodilator like nitric oxide and increased level of vasoconstrictor like endothelium 1, lung hyperinflation, a common feature of severe COPD, compressed pulmonary vessel, mechanical further altering blood flow and pressure. Moreover, COPD exacerbations characterized by sudden worsening of symptoms can actually increase pulmonary artery pressure, accelerating disease progression. Together, this pathophysiological mechanism explain why COPD patients often develop PH and highlight the need for comprehensive treatment strategy that address both the pulmonary and cardiovascular aspect of the disease. In pulmonary hypertension, the vessels undergo significant changes that compromise their function. According to Alkani, endothelial dysfunction is a hallmark of pH, reduce the synthesis of vasodilator like nitric oxide and prostacyclin, while increasing vasoconstrictor such as endothelin 1. This imbalance leads to chronic vasoconstriction and persistent high blood pressure within the pulmonary arteries. Over time, the smooth muscle cells within this vessel proliferate, thickening the arterial walls and narrowing their lumen. The progression of the changes can lead to fibrosis, whereby normal vascular tissue is replaced with fibrous, non-functional material, further decreasing arterial compliance. As these pathological changes accumulate, they result in elevated pulmonary vascular resistance, increasing the load placed to the right ventricle of the heart. The right ventricle, which normally pumps blood at lower pressure, responds initially by hypertrophy, meaning thickening, to maintain blood flow. However, chronic pressure overload can lead to right ventricle dilation, dysfunction, and ultimately core pulmonary, meaning right side heart failure. The interplay between these vascular changes and the heart compensatory mechanism underscores the importance of early detection and treatment of pulmonary hypertension in patients with lung disease like COPD. Pulmonary hypertension, in the context of chronic obstructive pulmonary disease, present a complex symptomology that compounds the challenges of managing COPD alone. One of the earliest and most noticeable symptoms is dyspnea, or difficulty breathing, which become more prominent during exertion and progressively worsen as pulmonary hypertension advances. This arises from increased pulmonary pressure and reduced oxygen exchange effectively in the lungs. Fatigue is also a prominent symptom, often stemming from diminished cardiac output and the body's reduced ability to deliver oxygen to tissue during physical activities. Patients may also experience chest discomfort, typically described as tightness of pressure, which can be result of right ventricular strain from the elevated afterload. Palpitation or irregular heartbeats may occur as the right heart struggle to adapt to the increased pressure demands. As right heart fatigue progresses, meaning cardiopulmonary, symptoms extend to systemic venous congestion, manifesting as peripheral edema, particularly in the lower extremities. This symptom highlights the systemic impact of pH on COPD patients, demonstrating the need for a multidisciplinary approach to symptom management, ensuring disease progression. Accurate diagnosis of pulmonary hypertension in patients with COPD involve a combination of clinical and instrumental evaluations. A true clinical assessment, including a detailed patient history and physical examination, is essential to detect signs such as jugular venous distension, peripheral edema, and other manifestation of right side heart failure called pulmonary. Echocardiography is a non-invasive imaging technique, provide estimate of pulmonary artery pressure and assess right ventricle function. However, while valuable, it can sometimes be imprecise. Menzi show that the gold standard for diagnosis pH is right heart catheterization, which measures pulmonary artery pressure directly and confirm the diagnosis. This invasive procedure provides definitive data necessary for tailoring patient care. Pulmonary function tests assess lung function, helping to gauge the surface of COPD and its role in pH development. Imaging studies, including chest X-ray and CT scan, offer insight into structural lungs and heart change and are useful in ruling out alternative cause of pulmonary hypertension. The multifaceted diagnosis approach underscores the complexity of managing pH in COPD patients and the importance of distinguish its impact on disease progression and progress. The relationship between COPD and pulmonary hypertension is complex and multifactorial, like I said before, with chronic lung inflammation playing a central line. Inflammation in the airways, triggered by exposure to irritants such as tobacco, smoke, leads to structural lung change and contribute to altered pulmonary vascular tone. Chronic hypoxemia, a hallmark of COPD, induce stent vasoconstriction of pulmonary arteries in an attempt to match ventilation and perfusion in the lungs. While initially compensatory, persistent vasoconstriction causes vascular remodeling, with the thickening and narrowing of arterial walls. This process elevates pulmonary vascular resistance, imposing a greater load of the heart right ventricle, which must work harder to maintain adequate blood flow to the lungs. Over time, this increased workload can lead to right ventricular hypertrophy, dilation, and eventual failure called pulmonary. COPD exacerbation marked by sudden worsening of symptoms, further elevate pulmonary pressure, and accelerate pH progression. The interplay between chronic hypoxemia, inflammation, and structural change in both the lungs and heart highlight the bidirectional impact of COPD and pulmonary hypertension, necessitating comprehensive therapeutic strategies to improve outcome. Managing pulmonary hypertension in the context of COPD disease require a multifaceted approach that addresses both the underlying pulmonary disease and the cardiovascular complication. Oxygen therapy is a cornerstone of treatment aimed at reducing hypoxemia-driven vasoconstriction and lowering pulmonary artery pressures. Long-term oxygen therapy has been shown to improve survival in COPD patients with pulmonary hypertension. According to LTIF, pharmacological treatment may include vasodilator, diuretic to manage fluid retention associated with right side heart failure, and anti-inflammatory agent to reduce airway inflammation. However, vasodilator may be used cautiously as they exacerbate ventilation perfusion mismatching. Pulmonary rehabilitation encompassing supervised exercise program, nutritional support, and patient education enhance exercise capacity, reduces symptoms, and improve overall quality of life. Lifestyle modification such as smoking cessation, mentally unhealthy weight, and engaging in regular physical activity are crucial to slow disease progression and alleviate symptoms. Effective management of COPD exacerbation, including prompt treatment of respiratory infection and adherence to maintenance medication, minimize acute increase in pulmonary artery pressure and associated complication. The holistic management strategy highlights the importance of the interdisciplinary approach to improve outcome for COPD patients with pulmonary hypertension. Oxygen therapy plays a critical role in management pulmonary hypertension in patients with COPD. The therapy works by correcting chronic hypoxemia, that's a key driver of pulmonary vasoconstriction and elevate pulmonary artery pressure. By improving arterial oxygen saturation, oxygen therapy helps to reduce the vascular resistance within the pulmonary arteries, thereby decreasing the load of the right ventricle and slowing the progression of pulmonary hypertension. Arif showed that long-term oxygen therapy is particularly beneficial for COPD patients with severe hypoxemia, as studies have demonstrated its capacity to reduce mortality and improve overall quality of life. Despite its advantage, there are risks and precautions to consider. Hyperoxia or excess oxygen delivery can lead to detrimental effects such as respiratory acidosis and should be avoided. Careful titration of oxygen is essential to balance efficacy and safety. Patient compliance with long-term oxygen therapy is a common challenge due to lifestyle disruption, discomfort, or stigma associated with using supplemental oxygen. Strategy to improve adherence, including patient education on the benefit, addressing concern about social stigma, and tailoring the living system to suit patients' preferences. This holistic approach ensures effective utilization of oxygen therapy to mitigate pH complication in COPD patients. Pharmacology management of pulmonary hypertension in COPD aims to alleviate symptoms, show disease progression, and reduce complication. Vasodilators such as phosphodiesterase inhibitor, example like sildenafil, may be used to reduce pulmonary arterial pressure. To do their use must be cautious due to the risk of worsening ventilation perfusion mismatch. Diuretic, like furosemide, play a critical role in managing fluid retention caused by right side heart failure, reducing symptoms like edema, and improving exercise tolerance. We can also use anti-inflammatory agents, including corticosteroid or other inhaled anti-inflammatory, to get the underlying and the airway inflammation in COPD, which contribute to pulmonary hypertension progression. Bronchodilators, such as beta agonists and anticholinergics, improve airflow obstruction, reduce breathlessness, and enhance overall quality of life. In some cases, anticoagulant may be considered to prevent thromboembolic event in patients at increased risk. Right heart failure is a serious consequence of pulmonary hypertension in patients with COPD. It occurs as a result of increased pressure in the pulmonary circulation, which causes the right ventricle to work harder to pump blood through the lungs. Over time, this increased workload to right ventricular hypertrophy, where the muscular wall of the right ventricle thickens further, impairing the heart's ability to pump effectively. As a result, the cardiac output decrease will affect the ability to deliver oxygenated blood to peripheral tissues. Systemic venous congestion become a hallmark feature on right heart failure, manifesting as swelling in the legs, abdomen, meaning ascites, and neck jugular venous distension. This congestion is due to the backflow of blood, which increase pressure in the veins. Hypoxia or low oxygen level worsens as the right heart fails to pump efficiently, further contributing to shortness of breath. The patient also experienced a vicious cycle of worsening symptoms, including fatigue, fluid retention, and increased difficulty breathing. Pulmonary can be fatal if not managed promptly and effectively, making it crucial to address both the pulmonary and cardiac aspect of COPD and pulmonary hypertension. Pulmonary rehabilitation is a crucial component of managing COPD disease complicated by pulmonary hypertension. This multidisciplinary program aims to improve the patient's physical and psychological well-being through various strategies. Exercise training is the cornerstone of rehabilitation, as it helps improve cardiovascular fitness, reduce symptoms such as dyspnea, and enhances overall endurance. It allows patients to become less dependent on oxygen and improve the strength and efficiency of the respiratory muscles. Amasaki showed that the techniques such as sleep and diaphragmatic breathing help patients optimize their lung function and control symptoms during physical exertion. Nutritional support is also an essential aspect of rehabilitation, as COPD patients with pulmonary hypertension are at risk for weight loss and muscle wasting, which further impair their ability to perform daily activities. Psychosocial support is provided to help patients manage the emotional toll of living with a chronic disease, addressing issues such as anxiety and depression. Finally, education is a key in empowering patients to manage both COPD and pulmonary hypertension effectively, providing them with the knowledge to take an active role in their care and adhere to treatment plans. Pulmonary rehabilitation improves quality of life, reduces hospitalization, and enhances the overall management of this complex disease. Lifestyle change to prevent worsening of pulmonary hypertension in COPD. Lifestyle change plays an essential role in preventing the worsening of pulmonary hypertension in individuals with COPD. Kotilarov showed that smoking cessation is the more critical intervention, as continued tobacco use exacerbates both lung damage and pulmonary vascular change, accelerating pulmonary hypertension progression. Smoking can slow the rate of decline in lungs function and reduce the risks of further complications. Regular physical activity is vital in enhancing cardiovascular and respiratory fitness. While patients with COPD and pulmonary hypertension may experience limitation, tailored exercise program can improve endurance, reduce dyspnea, and improve overall cardiovascular health. Dietary modifications are also important, particularly in reducing sodium intake to manage fluid retention, which is common in right heart failure. Weight management is another key factor, as excessive weight can place additional strain on the heart and lungs, worsening both COPD and pulmonary hypertension symptoms. Additionally, managing mental health is crucial for individuals dealing with COPD and pulmonary hypertension. Anxiety and depression can interfere with treatment adherence and overall being, so addressing this concern through counseling, support group, or therapy can significantly improve quality of life and disease management. Now let's go to prognosis and life expectancy in COPD with pulmonary hypertension. The prognosis for patients with COPD complicated by pulmonary hypertension is highly variable and depends on several factors, including the severity of both conditions. In general, the patient of pulmonary hypertension worsens the prognosis for COPD patients, with mortality rates being higher compared to COPD patients without pulmonary hypertension. The progression of both diseases can be slow, but as pulmonary hypertension advances, right heart failure, meaning core pulmonary, can develop, leading to increased morbidity. Comorbidities such as heart disease, diabetes, or obesity can further complicate the management of both COPD and pulmonary hypertension, leading to worse outcomes. However, early detection and comprehensive treatment, including oxygen therapy, pharmacology management, and pulmonary rehabilitation, can slow disease progression and improve survival rates. In patients with end-stage COPD and pulmonary hypertension, the prognosis becomes more broad, and right heart failure can lead to end-stage respiratory failure. Palliative care becomes an essential part of the care plan for this patient, focusing on symptom management, improving quality of life, and providing support for both the patient and their family. Although the prognosis is poor for advanced stages, timely and appropriate intervention can help manage symptoms and enhance the patient quality of life. Management of pulmonary hypertension in COPD pharmacology approaches. Pharmacology management of pulmonary hypertension in patients with COPD is essential for improving symptoms and preventing complications, especially right heart failure core pulmonary. Saika showed that one class of medication commonly used is phosphodiesterase 5 inhibitor, such as sildenafil, which relaxes the pulmonary arteries, improves blood flow, and reduces pulmonary artery pressure. Endothelin receptor antagonists like bosentan are another important class of drugs that block the effect of endothelin, a substance that causes blood vessel constriction in the lungs. These drugs help to decrease pulmonary vascular resistance and prevent further damage to the right side of the heart. Prostacyclin analogs, such as epoprostenol, are also used to improve pulmonary circulation and reduce the strength of the heart by dilating the blood vessel. In addition to this target treatment, oxygen therapy is crucial for management hypoxia, which is primary contributor to pulmonary hypertension in COPD patients. Long-term oxygen therapy reduces the workload of the heart and improves survival in hypoxic patients. Diuretics may also be prescribed to manage fluid retention associated with right heart failure, helping to alleviate symptoms like swelling and shortness of breath. Together, these pharmacological therapies can help control the progression of pulmonary hypertension and improve the quality of life for COPD patients. In summary, pulmonary hypertension is a common and serious complication of COPDs, significantly impacting patient outcome. The close relationship between COPD and pulmonary hypertension, driven by chronic hypoxia, inflammation, and vascular change, make it essential for clinical to consider pulmonary hypertension in patients with advanced COPD. Early diagnosis using a combination of clinical evaluation and diagnosis tests such as echocardiography and right heart catheterization is crucial to improving outcome. Treatment strategies must be comprehensive, integrating oxygen therapy, pharmacology treatment, pulmonary rehabilitation, and lifestyle modification to manage both COPD and pulmonary hypertension effectively. Patient-centered care, which involve tailoring intervention to each patient's unique needs and circumstances, has been shown to improve symptom control and quality of life. As we move forward, early intervention, continuous monitoring, and a holistic approach to care will be the key to optimizing the management of COPD patients with pulmonary hypertension, ultimately improving survival and the quality of life for this vulnerable population. This is the references that I use for that presentation. And thank you so much, everybody, for your time. I really appreciate it. Thank you so much. Bye.